Welcome to Translating Science to Transform Clinical Practice, how MEK inhibitors are changing the treatment landscape of NF1 and NF1-associated tumors. My name is Bruce Korf. I'm a medical geneticist at University of Alabama at Birmingham, and I'm joined by Dr. Nicole Ulrich from Boston Children's Hospital and Harvard Medical School. Well, I'm going to begin with a brief review of the biology and clinical manifestations of NF1. NF1, of course, is a genetic disorder. The gene responsible is a large gene that is located on chromosome 17. It encodes a protein which is referred to as neurofibromin, and as you'll hear, it functions as a tumor suppressor and a negative regulator of the oncogene RAS. You'll hear more about genetic testing and the existence of some, but limited, genotype-phenotype correlations. NF1 is a clinical diagnosis, and for many years we've used diagnostic criteria that originally were established at the NIH in 1987, but recently, due to a large effort that was supported by the Children's Tumor Foundation with many international participants, diagnostic criteria for NF1 have been revised. These criteria include, as before, the presence of multiple cafe au lait macules, axillary or inguinal freckling, multiple neurofibromas or a single plexiform neurofibroma, optic glioma. One change in the criteria is either at least 2 iris Lish nodules or, and this is new, choroidal abnormalities, 2 or more choroidal abnormalities. A distinctive osseous lesion such as sphenoidal dysplasia or long bone dysplasia. And then another addition to the criteria now is the occurrence of a pathogenic non-mosaic NF1 variant. All of this requires 2 criteria to be fulfilled to establish an NF1 diagnosis, or the child of a parent who meets these criteria, where the child then fulfills at least 1 criterion. The data shown at the right that 70% are diagnosed by age 1, 95% by age 8, that was really on the old criteria. And of course, genetic testing does allow for much earlier diagnosis, as you'll be hearing. Well, just a brief overview of some other complications and associated clinical features. Children with NF1 often are short relative to other members of their family, but will have either an absolute macrocephaly or a relative macrocephaly, where they'll have what may be a normal-sized head, but short stature. Doesn't seem, though, that the head size is associated with cognitive function or the occurrence of structural brain abnormalities. Scoliosis is relatively common, sometimes associated with a paraspinal plexiform neurofibroma, but not always, and a proportion do require surgical treatment. There is an increased frequency of seizures in individuals with NF1, and neuroimaging would be recommended for new onset of seizures, although one does not necessarily always see a structural lesion. And headaches are common, and neuroimaging can be helpful to explore the possible causes, which could include Chiari malformation, could include a mass lesion, but often no imaging findings occur. This particularly when the headaches are not controlled by over-the-counter medications, and especially, of course, if there's any abnormality on neurologic exam. Vascular complications are important to recognize. A small proportion have congenital heart defects, such as pulmonic stenosis. There can be arterial stenoses, including coarctation, or stenoses at various points in the arterial tree, perhaps most notably renal artery stenosis, which would present with hypertension. Hypertension can also occur as a consequence of pheochromocytoma, and essential hypertension actually would be the most common cause of hypertension in adults with NF1. Very important, and I think Nikki will talk more about this later, cerebral vasculopathy can occur, including Moyamoya syndrome, and this can predispose to stroke, and it can occur spontaneously in NF1. It can also occur in consequence of certain treatments, especially radiation treatments. Neurocognitive dysfunction is very common in NF1, is noted here, 30 to more than 50%. A subset will have IQ at the 70 or below range, and the histogram you see is an IQ curve that was actually put together by Dr. Catherine North many years ago, actually, and it shows a bimodal distribution in the blue bars. I've superimposed on here some green bars, which are not from her data set, but instead are individuals with whole gene deletions of NF1 who tend to be on the lower end of the IQ curve, something I'll return to a little bit later. There can be visual spatial problems, difficulties with executive function, and as well attention deficit disorder with or without hyperactivity. Underachievement in school is very common. One often sees areas of enhanced T2 signal intensity in areas like the basal ganglia, as you see in the MRI at the right, which over time tend to disappear. Social dysfunction is also quite common. Individuals with NF1 are often socially isolated, more likely to be rejected or teased, on average tend to be subject to problems with peer relationships, may have problems with loneliness. There is an increased frequency of autism spectrum disorder in NF1 as compared to the general population, and overlap with autism spectrum disorder may be contributed to by low social cognitive function. NF1 is a classic dominant transmitted disorder. An affected individual has a 50% chance of transmission, equally affecting both males and females, or transmitted by males and females. However, about half of instances are sporadic, as shown in the small pedigree on the right, where neither parent shows signs of the condition and where the child is affected by a new genetic mutation that arose in the sperm or egg cell that formed that child. Genetic testing has been available for nearly 20 years. This is a slide provided to me many years ago, actually, by Dr. Ludwig Messiaen, who has really been the pioneer in terms of developing a kind of practical clinical genetic test for NF1. And the main point of this slide is that mutations are exceedingly diverse. Several thousand actually have been defined as pathogenic variants over the years. The dots below the diagram of the gene are small mutations in the coding sequence of the gene. The vertical lettering are splicing variants. The horizontal bars are deletions or duplications. Almost no two individuals have exactly the same variant. There actually, with all of that, are a handful, but not that many, genotype-phenotype correlations. Most of the variants cause loss of function of the NF1 gene, and for the most part, it may not matter exactly where and how that was accomplished. Once it's been accomplished, the gene doesn't work, the protein isn't made, and the consequence is the same. But there are some specific examples of genotype-phenotype correlations. Deletion of the entire NF1 gene, along with several surrounding genes, tends to produce a severe phenotype, which I'll illustrate in a moment. There are several others. I don't think I'll read them all to you here. I'll just make the point that these individually tend to be quite rare. If you are seeing an individual with one of these variants, it does give you some idea of what to expect. But by and large, the mutations are usually not highly predictive of the specific phenotype. Here's an example of the whole gene deletion with what tends to be a large number of cutaneous neurofibromas that form at an early age. And these are the individuals often at the lower end of the IQ curve in the green bars that I alluded to earlier. The fluorescence in situ hybridization on the right, actually these days not really the best way to demonstrate the deletion, but does show dramatically. There's marking of chromosome 17 in green, and you see the normal one in the lower right that shows a green and a red, indicating the NF1 gene. In the upper left, you don't see that because of the deletion. Well, mutation testing now is quite available, and it is especially useful in a variety of settings. Very commonly, a child who presents with multiple cafe au lait spots, which is usually the presenting feature, but no other clinical features, which would define an instance of an uncertain diagnosis because only one clinical criterion at that point in time is met. In the setting of cafe au lait macules with skin fold freckling, it's important to rule out Legius syndrome, which is an annotation, by the way, in the diagnostic criteria that I showed at the beginning. And genetic testing will distinguish between these two entities. Individuals who seem to have multiple spinal neurofibromas but have very few other manifestations, for example, oftentimes very few cutaneous neurofibromas, sometimes have missense or splicing mutations. So germline testing can be helpful looking for that so-called spinal phenotype. Of course, it's useful for both genetic counseling and for family planning purposes. Well, with this brief review of the phenotype, let me now speak specifically about the impact of MEK inhibitors on the treatment of NF1-associated plexiform neurofibromas. If one looks at the taxonomy of nerve sheath tumors in NF1, what's labeled here as dermal, or probably better referred to as cutaneous neurofibromas, are the most visible common aspect in adolescents and especially in adults with NF1. And these, if you look at the molecular level, tend to show loss of NF1, both alleles, a point I'll return to in just a moment, but generally not other genetic changes. Plexiform neurofibromas involve major nerves and branches of those nerves. You can see it radiographically, and histologically, these don't look particularly different from cutaneous neurofibromas, and they too show at the molecular level typically loss of both NF1 alleles. So-called atypical neurofibromas tend to show up as nodular lesions, relatively homogeneous by MRI, but not lots of mitotic figures histologically. And in addition to NF1 loss, often shows CDKN2A variants. And then the kind of far end of the spectrum is malignant peripheral nerve sheath tumor that affects somewhere in the 8 to 13% range, and of course have the characteristics histologically of a malignancy, and typically have, in addition to the variants already mentioned, accumulation of other mutations, as shown here, especially TP53. Plexiform neurofibromas are benign tumors, and they're common in individuals with NF1, occurring in 40 to 60% of affected individuals. They tend to grow along nerves and nerve branches, both on the surface and within the body. They tend to have variable natural history. We think that they're probably congenital, but not always that obvious in infancy, and have unpredictable growth patterns, many times not growing at all or only growing slowly. And it appears that the fastest rate of growth usually occurs in early childhood. They're multicellular lesions with axons, Schwann cells, fibroblasts, perineural cells, mast cells, collagen, and extracellular matrix. And as shown at the right, there is often a disrupted perineurium. So I've mentioned NF1 functions as a tumor suppressor, and what that means is that an individual with NF1 begins life with heterozygosity for a pathogenic variant in NF1, actually in all cells of their body. Here we focus on Schwann cells, which is the origin of neurofibromas. But to have a neurofibroma occur, the normal allele, the unaltered allele of NF1, also needs to undergo mutation, which can range from loss of the gene copy to just a single nucleotide change in the gene, leaving that Schwann cell with no functional copy of the NF1 gene, producing no neurofibromin. It appears, though, that that's not sufficient to cause a neurofibroma to form, but also requires signaling between the Schwann cells and other cells in order to actually generate a neurofibroma. But by virtue of this, NF1 is defined as a tumor suppressor gene. As mentioned earlier, the acquisition of other genetic changes underlies the malignant transformation in MPNST. When thinking about complications of plexiform neurofibromas, there are a number of potentially serious ones. Now, pain can occur sometimes due to, for example, nerve compression, although in fact, plexiform neurofibromas, in spite of oftentimes being large, are very often not painful inherently. And you always need to be alert to the possibility of pain in a plexiform neurofibroma being a sign of malignant change. In addition, there can be impaired function due to compression of nerves due to the plexiform neurofibroma. There certainly can be disfigurement that ensue from the growth of a plexiform neurofibroma, and occasional, potentially even life-threatening changes due to compression of the airway or of large blood vessels or compression of the spinal cord. As mentioned, malignant change to malignant peripheral nerve sheath tumor is a obviously very severe complication that we need to be alert to. It's usually unexplained, persistent pain and growth out of proportion with the rate that the tumor was growing, which may only involve a component of the tumor that are signs to suggest a malignant peripheral nerve sheath tumor has occurred. And as mentioned earlier, growth of plexiform neurofibromas is most common to see in childhood or teen years. Well, there have been very limited access to treatment over the years. Surgery has been the mainstay, but resection is usually limited. The tumor can be very difficult to get to without causing morbidity, including bleeding, for example. And it often also is so closely associated with the nerve that nerve damage is a major risk of surgery. And the tumors tend to grow back from what is inevitably partial resection. Radiation therapy has really unknown benefit, and there is a real concern about an increased risk of malignant change as a consequence of radiation. And these have typically not responded to standard cytotoxic chemotherapies, and there's once again concern about the risk of malignant change. And so the real interest in recent years excuse me, has been towards molecularly targeted agents. And over the years, there have been several efforts to identify potential treatments. Tipifarnib, which interferes with binding of RAS to the cell membrane, really didn't prove to be beneficial to a point where it would be clinically useful. But the study done at the National Cancer Institute was a crossover study, and it did give really useful natural history data. The NF Clinical Trials Consortium tested sirolimus, and there was a moderate increase in time to progression, but not to a point where it would be viewed as mainstay of therapy. There was some response to pegylated interferon, where it did increase time to progression. And some individuals have responded to imatinib, though not probably in numbers to make this a kind of mainstream therapy. The NF Clinical Trials Consortium did a phase 2 trial of cabozantinib, which is a multiple receptor tyrosine kinase inhibitor. This particular trial was for individuals aged 16 or older with inoperable or progressive plexiform neurofibromas, or ones causing significant symptoms, and a 20% or more reduction of volume was a endpoint, as well as monitoring of toxicity and a variety of quality of life measures. This shows the response, where there was a partial response in 42% with this. And there were some grade 3 serious adverse events, as you see listed here, and several patients required dose reductions in treatment of these adverse events. Well, looking at a simplified cartoon of the RAS signaling pathway, where a lot of excitement has been directed in recent years has been the application of MEK inhibitors, inhibiting part of the cascade from RAS to the cell nucleus. And there are several MEK inhibitors that are shown at the right that are available, and many of which have undergone testing in the context of plexiform neurofibromas. I think the landmark study began with a phase 1 trial at the National Cancer Institute using the MEK inhibitor selumetinib. This was for children aged 3 to 18 years of age with inoperable plexiform neurofibromas with the potential to cause morbidity. The medication was well tolerated. They established a maximum tolerated dose, and then also noticed partial responses in 71%, as you can see in the illustration at the right, also using a 20% reduction of volume cutoff to define partial response. This was followed by a phase 2 trial called SPRINT, in which selumetinib was used to treat children with NF1 and inoperable plexiform neurofibromas, as you see here, with the same treatment response endpoint as well as a number of secondary endpoints. It was a complicated study with lots of different approaches to measuring outcomes depending on the location of the plexiform neurofibroma. 50 individuals were enrolled, as you can see, with a median age of 10.3 and a pretty wide range of plexiform neurofibroma tumor volume. And here you can see the response, again, with the 20% reduction in volume threshold, where partial response was identified in 74% and a durable partial response lasting a year or more in 56%. In addition, there were a variety of outcome measures, as mentioned earlier, and the blue shows where there were instances of improvement in many of these outcome measures, which was an important concomitant to the radiographic response. And you can see at the right instance, the graph shows in red the change in tumor volume after the initiation of the selumetinib. Now, treatment did require continuous treatment. So in instances such as shown here, where the medication had to be held because of a decrease in left ventricular ejection fraction, the tumor began to grow back more or less in line with its previous rate of growth. And then restarting selumetinib at a lower dose restored that response. So just over a year ago, selumetinib did achieve approval by the FDA, labeling for treatment of pediatric patients 2 years of age or beyond with NF1 with symptomatic inoperable plexiform neurofibromas. Now, there have been trials or are ongoing trials with other MEK inhibitors and plexiform neurofibromas, and the study designs are pretty similar from one to the other. This is a NF Clinical Trials Consortium trial, and here the target was individuals 16 years or older with NF1 and symptomatic or growing plexiform neurofibromas, very similar endpoints, and you can see the response here, which was 42%, showing a partial response, and you can see the toxicities, no ophthalmologic toxicity, no grade 4 or 5 adverse events, no discontinuations due to dose limiting toxicity. Acneiform rash was the most common toxicity, and a few that required dose reductions. There is an ongoing trial with a very similar study design that the consortium is doing in collaboration with PNOC, looking at binimetinib, and those results are pending at this point. I'm going to conclude with a very brief case snapshot. This is a teenager who presented with a very large facial plexiform neurofibroma. You can see that this involved the left side of the face, including the scalp. And this individual had actually had debulking of this tumor done prior to when we saw the patient, and had had enucleation of the eye, so it already lost vision on that side. The tumor had grown back after resection and seemed to have stabilized in size, at least for a short period of time, since the surgery to the point when we first saw this individual. Symptoms were relatively mild, other than significant disfigurement and some occasional headaches. So when thinking through about whether to treat, a number of questions are asked. Is the tumor progressive? Well, it had been for sure after treatment, though in the time since then it had been relatively stable, albeit not so easy to detect clinical change. Is it disfiguring? Well, yes, profoundly so, actually, as you can infer from the MRI. Does it cause major symptoms or morbidity? Examples being airway compression or cord compression? Well, no, not really. Does it have the potential? Given its enormous size, we thought it might, although it's difficult to be sure. Can it be resected without unacceptable morbidity? Definitely not. And we'd already seen how it grew back after treatment. And finally, in our judgment, was this patient able to comply with the treatment regimen? And the answer was yes, we thought so. So selumetinib actually was started clinically, and the MRIs that you see at the right show before and after, or before and after about 18 months of treatment. And truthfully, it's difficult to find exactly comparable levels, and you can convince yourself that there's some reduction of volume, and this was the impression that the family had looking at this child as well. Probably better to look at the volumetric analysis that was done at the NCI, not as part of a clinical trial, but we're willing to provide this information for us. And the red shows the change in tumor volume from the time of starting the selumetinib. There, of course, are some measurement error in this, but it shows pretty clearly a reduction of volume, not quite as of this point in time to the stage of 20% reduction, but definitely some response. And that's where we are. It's a profoundly disfiguring tumor. It has responded to selumetinib, and at this point in time, treatment is continuing. The likelihood that it will completely shrink this tumor, I think is probably low, and there's now discussion about whether there are any other options or whether surgery followed by selumetinib treatment might be a possibility. It's a difficult tumor to manage for sure, and it's pretty clear selumetinib has been helpful, but there's a long way to go in treating this this teenager. Nikki, I don't know if there's anything you'd like to comment on here.
Yeah, so I definitely would agree with the decision to move forward with treatment with the MEK inhibitor. And it does appear that there's been a significant response. I think from the data, I think there's still opportunity for increased shrinkage. And I would agree that consideration of debulking now may be back on the table with then a reinitiation of the MEK inhibitor. I think this is a tricky situation too, where there's probably more potential for morbidity because it looks like the individual has sphenoid dysplasia and that the original tumor may have wrapped around the internal carotid. So they're at risk for vascular effects and others. So certainly bears watching as well.
Okay, thank you. So some final take-home points on NF1-associated plexiform neurofibromas. They are common in the setting of NF1, not always symptomatic, however, but some can lead to disfigurement and or morbidity. Most rapid growth usually occurs in childhood or teen years, and progressive or symptomatic plexiform neurofibromas may respond to MEK inhibitors. Treatment decisions should be based on shared decision-making that includes the patient and family, as well as the clinical team. And the MEK inhibitors can be well tolerated, but do require careful surveillance and management by an experienced team. And with that, I will turn it over now to Nikki to talk about low-grade gliomas and other tumors.
Thank you for that introduction. Today, I'll be talking about NF1-associated low-grade gliomas, exploring rational targeted approaches to enhance outcomes. It's important to take a step back and talk a little bit more broadly about NF1-associated gliomas. We see low-grade gliomas in about 20% of individuals with NF1. The most common of those is the optic pathway tumor, and that is the most common brain tumor in children with NF1. They occur mainly in children with a peak period of 2 to 6 years. As with many tumors in NF1, they're typically slow growing. The brainstem location is the next most frequent. These tumors are generally low grade, most likely juvenile pilocytic astrocytoma, although occasionally we can see higher grade tumors or glioblastoma. One of the challenges is that for tumors located in the optic pathway or in the brainstem, it's very difficult to get pathologic specimens, and in most cases, they're not biopsied. In young children and infants, we look for tumors that may be associated with an isolated optic nerve or bilateral optic nerve. In older children, more variable locations, including the brainstem and the corpus callosum, although really they could occur anywhere. And in adults and late childhood, there's a higher frequency of high-grade tumors. They may not necessarily be pilocytic or low-grade. As I mentioned, optic pathway gliomas typically occur in young children. They may cause vision loss, and I think one of the tricky things is that just because there's a tumor on imaging or even a change on imaging, it does not necessarily equate to changes in visual acuity or visual outcomes. So assessment of progression and response to treatment can be a challenge. It is often the case that the MRI can show progression, whereas the vision is stable, and the vision can show deterioration with a stable MRI. And this reinforces the idea that the ophthalmologic evaluation is crucial for the evaluation. One must remember, as you heard from Bruce earlier, that many of these children have developmental delay or ADD. So we're faced with the difficulty of doing a ophthalmologic evaluation in a wiggly toddler who may already have some predisposition to attention difficulties and/or learning issues. So most NF1 low-grade gliomas do not need treatment, and I should say that 3 times over. There's a limited understanding of which tumors are likely to require intervention, and therefore identification of prognostic factors is crucial to minimizing the morbidity of the tumors, as well as to limit the treatment to only those individuals who have tumors at risk or are truly progressive. Standard therapies for symptomatic low-grade gliomas are limited compared to those in individuals without NF1, and there's a higher risk of long-term consequences of treatment in individuals with NF1. The identification of novel outcome measures, as well as new potential targets for treatment of NF1 low-grade gliomas, is crucial. So as with the situation you heard described with plexiform neurofibromas, there's no one factor that is a slam dunk in terms of deciding whether or not to move forward with treatment or not. So some of the potential categories would include change in visual acuity or new visual field loss, or visual field acuity worse than 1 logmar in one eye, and also with compromise in the other eye, and/or significant tumor progression by MRI with suspected vision loss, but in a child where the visual acuity testing is unreliable. In addition, concerning signs or symptoms may include tumor progression or other ophthalmologic findings, such as proptosis or abnormal eye movements. A newly diagnosed individual with normal visual field or visual acuity likely does not need treatment. And you can see in the middle panel that there are some factors that also push in the direction of treatment. So chiasmatic or pre-chiasmatic involvement, unreliable visual acuity, and all of these are factored into the decisions regarding treatment, considering treatment, increased vigilance or observation, and normal surveillance. The landmark studies actually have evolved more recently, but we do have a number of different treatment modalities. So surgery does come on the table. However, it's most often not pursued because there are other risks. So this is a high real estate zone in terms of other cranial nerves, in terms of the internal carotid artery coming up through the skull base, and therefore, as well as the hypothalamic pituitary axis, and therefore there are surgical risks, including further compromise in vision by removing a portion of the functional nerve, endocrine changes due to impact on the hypothalamus, and risk of stroke. Indications for potential surgical options include a unilateral optic nerve with absent or severe vision loss, where there's retained vision in the other eye and no involvement of the chiasm, painful or disfiguring proptosis, or hydrocephalus. Radiation therapy is an option for treatment, and it actually does work, but it has significant toxicity, as I'll show you in a moment. And these include impacts on the vision system, endocrine function, stroke or vascular changes, cognitive changes in an already leveraged population, and secondary transformation. One such example is a patient of mine that I show you here. This is a young woman who, as a child, was treated with radiation therapy for an optic pathway glioma. This is before we had standard therapy, chemotherapy options. She had a known head and neck plexiform neurofibroma and was found later to have a low-grade glioma, or presumed low-grade glioma in the brainstem, and went on to receive a second course of radiation. Her plexiform neurofibroma then experienced malignant degeneration into an MPNST, to which she ultimately succumbed. So we can see new tumors developing, and we can see existing tumors transform into an MPNST. Another example of a radiation side effect is radiation-induced vasculopathy. So children with NF1 who receive radiation are at increased risk for moyamoya, and it occurs more rapidly and at lower doses than in children without NF1. And this is a large case series of over 400 patients who were treated for childhood low-grade glioma, some with NF1, some without NF1. And you can see that there was a dose-dependent effect, whereas children with NF1 were more likely to get moyamoya than their comparable age-matched controls who did not have NF1, and they did it at lower doses of radiation. There are some good chemotherapeutic options, and the first study used combination therapy with carboplatin and vincristine, which is a standard therapy for low-grade gliomas. The 5-year progression-free survival was actually quite good, 69%. However, it was actually significantly better in children who had NF1 than children without NF1. The response to vision was more variable. So about a third improved, about a third stayed stable, and about a third worsened on therapy. And the visual acuity response did not necessarily match up to the radiologic response. There really is no standard second-line chemotherapy for patients with NF1. Many of the time, these chemotherapeutic options include alkylators, which may increase risk for long-term development of leukemias. There are targeted therapies which are coming into use, as well as molecularly targeted agents, and I'll talk about these in a bit more detail. So the NF Clinical Trials Consortium recently completed a clinical trial using the mTOR inhibitor everolimus for recurrent radiographic progressive NF1 low-grade glioma. The study objectives were to assess the imaging response in individuals less than 21 years of age, and they must have received a conventional carboplatin-based regimen before proceeding on to the clinical trial. The overall therapy was well tolerated. Very few individuals had high-grade toxicity. There were no grade 4 or grade 5 adverse events, and there was a relatively good response overall in terms of freedom from progression. Retrospectively, we reviewed the visual outcome data, which was somewhat limited because it wasn't required as part of the study, but we had 14 children who had tumors located in the optic pathway system where we had visual outcome data. We had about 4 eyes that showed improvement, 19 were stable, and only 2 were worse. And importantly, again, the visual outcome did not necessarily correlate with the radiologic outcome. There was also a pediatric brain tumor consortium phase 2 trial of selumetinib in children with recurrent low-grade glioma. There were 25 children, 13 of them had an optic pathway glioma, and the 2-year progression-free survival was 96% with a response rate of 40%. Importantly, they also tried to retrospectively collect visual outcome data and had similar findings with improvement in visual acuity in 2 eyes, stable visual acuity in 16 eyes, and worse acuity in 0 eyes. Ultimately, refined outcome responses are going to be important moving forward, as they have been with plexiform neurofibromas, in order to interpret exactly which individuals need to have treatment and what are the criteria for assessing success of the treatment. There are a number of clinical trials moving forward. One of these includes a clinical trial of vinblastine versus the combination of vinblastine plus bevacizumab. And this could be in tumors that are progressing after radiation, or in children who are chemotherapy naive, meaning they've never received treatment before. This study is ongoing, so we do not have the results of that, but vinblastine is a drug much like vincristine, and bevacizumab is an anti-angiogenic therapy. And so it'll be interesting with this combination approach to see whether or not there's any increased treatment response. There's an ongoing children's oncology group trial also comparing selumetinib, which you heard about before, versus carboplatin vincristine in children who've never had a treatment before for an NF1-associated low-grade glioma. This is a phase 3 randomized study up front, and the primary objectives are to determine whether or not event-free survival with selumetinib is non-inferior to carboplatin vincristine. In addition, it will assess prospectively visual acuity outcomes, and this will be the first study that actually does prospectively evaluate visual acuity. These are quite different therapeutic approaches, as one is completely oral and the other is more in-clinic intravenous intensive. So these effects on household function, parental work, and other assessments will be also very important. Taking a step back and putting this all together, we have a number of MEK inhibitors that are available for NF1-associated tumors, and that includes plexiform neurofibromas and low-grade gliomas. You heard about selumetinib and mirdametinib, as well as the ongoing clinical trial of binimetinib. However, there are also trametinib and cobimetinib. None of these have been compared in the NF population or other populations side by side. So it's difficult to know whether or not one has a therapeutic advantage over the other. Some of them have been assessed in NF-associated tumors, and this includes selumetinib, which has been assessed both for plexiform neurofibromas and low-grade gliomas. Currently, it's available only in a tablet, although sprinkles and liquid are in development. And there's some thought to move forward with combination therapy using selumetinib plus another targeted therapy, such as everolimus. The next drug, trametinib, has had a clinical trial in plexiform neurofibromas and moving forward in low-grade gliomas. It is available in tablet and liquid. Mirdametinib is ongoing, but is also only available in tablet. Binimetinib is available in tablet and liquid, and the results we expect to be available soon. And cobimetinib is available in tablet and liquid. I should say, in the studies that you heard about earlier, one important thing to remember is that selumetinib is approved in children with NF1, and the patient population was a younger population than the results for which we have for binimetinib and mirdametinib moving forward, as well as for cabozantinib, where it was an adult population. So when we think about the response rate, we have to remember that adults may not respond as vigorously or intensely as children in the selumetinib trial. In terms of MEK inhibitor toxicity, in young patients and in old patients, acneiform rash and paronychia are the most common symptoms. Fatigue is also seen in some GI difficulties. Pediatric patients, however, may respond differently, and there's some anecdotal evidence that some children treated with MEK inhibitors may experience muscle weakness or hypotonia that resolves after discontinuation of therapy. In terms of prescriptions or prescribing MEK inhibitors, some MEK inhibitors need to be taken on an empty stomach, which means that no food 2 hours before or 1 after the medication. It is important not to ensure that the individual is not taking any CYP3A4 inhibitors, such as some anticonvulsants and grapefruit juice. It also contains vitamin E, so concomitant vitamin E supplement is not recommended, and monitoring is very important. So this not only includes a clinical assessment aggressive skincare management, performance of echocardiography at intervals on therapy, because we would hold drug for loss of ejection fraction, ophthalmologic evaluation for rare retinal toxicity, and laboratory studies. The most common laboratory abnormality is an asymptomatic elevation of CPK. So I'm going to give you a case snapshot of a child that I evaluated with a head tilt. This was a 4-year-old boy who presented to the pediatrician and was noted to have cafe au lait maculas and inguinal freckling. NF1 was suspected, and the primary care doctor obtained a screening MRI. The patient was then referred for urgent neurosurgical and neuro-oncologic evaluation. So the initial MRI is shown on the left. Now, despite the striking abnormality on imaging, the examination was completely normal. And I think even though this is quite abnormal, the instinct would be to go ahead and treat this because of the abnormal signal intensity and the size of the lesion. However, we chose to continue to monitor. A few MRIs later, as seen about 12 months after the initial assessment, and it had a very different distribution of signal abnormality, but there was now expansion down into the cervical cord. We had a lot of discussion about whether or not to proceed with treatment in the setting of a normal examination, and ultimately we decided to continue observation. You can see on the right the MRI at 24 months, and again the child was asymptomatic. No treatment was given and the lesion ultimately resolved. The exam remained normal throughout. And I think this is one of those situations where at every juncture, you put all treatment options on the table. However, in the setting of a completely normal examination, we had decided not to move forward with treatment. Had we given this child treatment with either conventional chemotherapy or a targeted therapy, we would have considered this a treatment success because of the radiologic response. However, this occurred on its own without any intervention. So here we're faced with an important question: to treat or not to treat? All of these discussions need to include all of the tools in the toolbox and important considerations such as, is the tumor progressive and does the individual have any symptoms? One potential treatment possibility is observation. And in fact, this is a very possible treatment selection. Radiation therapy, for the reasons that I showed you earlier, is likely not going to be our #1 treatment recommendation. Surgery is also likely not going to be our #1 treatment recommendation, given the location in the brainstem and the likely morbidity from surgical approaches. Therefore, we would move to medical therapies. One avenue would be traditional chemotherapy. This might include vincristine and carboplatin, vinblastine, or monthly carboplatin. Consideration of a clinical trial, such as vincristine carbo versus selumetinib, a new clinical trial through the NF Clinical Trials Consortium using poly-ICLC, or in the future, some combination therapy of a MEK inhibitor, mTOR inhibitor, for example. And then we have the option of targeted therapy using either selumetinib or another MEK inhibitor, or everolimus or another mTOR inhibitor based on the data that I showed you. Bruce, I want to pass this over to you to see if you have any thoughts on the case as well in terms of decision-making.
Well, Nikki, I think you've kind of framed the issues very well. And, to me, this is an instance where we always need to keep in mind that we need to treat the patient and not the imaging studies. Very often in children with NF1, we see findings on MRI that we honestly just don't entirely understand and which may not correlate with any particular clinical issue that individual is facing. And so the decision to treat can be a complicated one, but I would emphasize that we're treating the person in this instance and not simply the imaging study. And it also underscores the importance of shared decision-making when it comes to treatment decisions that includes the patient and the family as well as the care team. These can be very complicated, but very significant decisions to make.
100% agree, both for plexiform neurofibromas and for optic pathway or other low-grade gliomas. Thank you. And that's a good segue into our take-home points on NF1-associated low-grade gliomas. Taking a step back, what is the indication for treatment and what are the goals of treatment? Are there symptoms in that individual? As mentioned, surgery and radiation therapy have limited indications in this population. Traditional chemotherapy is an effective treatment option and proven. And molecular therapies now are emerging that have demonstrated promise, although long-term toxicity, particularly in children, is still undetermined, and children may have very different side effects than adults who've been treated with the same medications. MEK inhibitors are in active clinical trials for NF1-associated low-grade gliomas with a renewed focus on tolerability, patient satisfaction, evaluation of functional outcomes, in addition to classic imaging endpoints, in a similar way to the trials for plexiform neurofibromas. And with that, I'd like to pass it back to you, Bruce.
Well, thanks very much, Nikki. Just by way of summary, I'll make the point, as somebody who's been seeing individuals with NF1 for many, many years, this is an unbelievably exciting time. We do have some treatments, as you've heard, that really do make a difference in terms of quality of life. But even more, I think we are in an era now as we learn more and more about the underlying pathogenesis of NF1, where the promise of additional approaches to treatment is a very realistic one. So I think individuals with NF1 increasingly can look forward to approaches to management that really were undreamt of at the time when I started seeing patients many years ago. All right, we're now going to take some questions, and the first is asking whether there are radiographic or other biomarkers available for surveillance in children and when to start. I'll start here and then Nikki can chime in. So, we certainly would love to have things that would predict for us who is likely to progress and who is likely to require treatment. We do now have standards for the kinds of imaging studies that are useful to do. But I would say that we really don't have, for example, a reliable blood biomarker that is going to tell us when a tumor has, for example, progressed to malignancy. And radiographic imaging as it stands is not that good at, for example, distinguishing between malignant peripheral nerve sheath tumors and the more atypical neurofibromas. Fluorodeoxyglucose PET scanning can be useful in distinguishing malignant tumors. But the need for example, blood biomarkers would be wonderful to have, so far has been elusive. And Nikki, maybe you want to add to this.
Yeah, I think this is a really important question, and there are several efforts currently in trying to address that. So one of them is the RAINS group, Response Evaluation in Neurofibromatosis and Schwannomatosis. And there's in fact a biomarker group, imaging group, and groups that are thinking about outcome measures for low-grade gliomas, plexiform neurofibromas, pain, function. And those we think are going to be important as a surrogate biomarker for clinical trials in particular. And there's a multi-center international study sponsored by the Children's Tumor Foundation for children with NF1-associated optic pathway gliomas. This study will collect diffusion tensor imaging, visual field information on children who are treated and who are not treated for an optic pathway glioma to see if we can determine what are those indicators for treatment.
Great, thank you. Well, here's another question. It concerns individuals with NF1 who perhaps are not being followed on a regular basis in an NF clinic and are now potentially eligible for treatment and may not even be aware that there is a treatment, and the individuals following them may similarly not be aware that there is a potential for treatment. And the question is really, how do we make sure that the word is out, both in the NF clinic population and in other specialists, that there are potentials for treatment at this point. Nikki, do you want to comment on this?
Sure. So I'm biased, but I do feel that individuals with NF1 should be followed by an NF specialist and try to make sure that they are, particularly in transitioning to adulthood. And I think it's important for a number of reasons. One, because as you mentioned, Bruce, because of potential treatments that are available now, but the others because there are standard management recommendations that have evolved both for adults and pediatric patients with NF1. And we want to make sure that we're looking forward rather than retrospectively running to catch up to an issue that came up because proper surveillance wasn't being done. And also I encourage my patients to participate in the registry through the Children's Tumor Foundation, because that's a way for them to be aware of new treatments coming down the line that may be applicable.
Yeah, I certainly agree with that. You know, one of the most distressing things is when an individual is seen with NF1 who has not been followed and finally does show up in NF clinic with what often turns out to be signs of a malignant peripheral nerve sheath tumor that had gone really kind of unrecognized for a long period of time. And certainly that's the kind of outcome we would very much like to avoid. Well, there's another question asking about risks of routine immunization in the context of treatment of infants and young children. And Nikki, do you want to try to address
Sure.
that?
The question was whether or not young children and infants who are in the process of being treated with biologic approaches or MEK inhibitors, if they should get routine immunizations. And the long and the short answer is both yes. These are not considered to be immune suppressive drugs, and therefore it's just as important as it is for a child with NF1 who's not being treated and for a child without NF1 for them to get childhood immunizations.
Right, yeah, certainly agree with that. There's a question about the long-term toxicity of the biologic approaches, for example, MEK inhibitors in young children. I'll just make the point before we get too far here that, you know, it's only a few years that we've had experience with MEK inhibitors to begin with. Obviously, it's a relatively new approach to treatment, and especially its clinical use is only roughly a year old. I personally have some patients who had participated in clinical trials and have been on treatment for many years and seem to be doing extremely well on it. But I would guess that the really long-term effects, we are really going to need to be studying that over a period of time in order to fully understand it. Nikki, do you want to add here?
Yeah, 100%. I think not only have they not been around for very long in pediatrics, they also haven't been around very long in adults. And as we discussed earlier, children are not many adults, and they have different side effects, and these medications are given in the context of a growing, developing child. So I don't think we have enough long-term data on what those issues can, might, and will be.
Thanks. I think I have time for one more question. I think, Nikki, you'd be best able to answer this. Optic nerve gliomas, is there any indication for low-dose chemotherapy treatment for optic gliomas in NF1?
So my sense is that this question is asking about almost preventative type therapy once an optic glioma is identified. And this question has come up both for optic gliomas and other tumors in NF1, like a plexiform neurofibroma. And I think that if we reach a point where we're able to determine who is going to progress ahead of time based on OCT evaluations, DTI, other imaging, other biomarkers, then the consideration for a preventative or low dose treatment may be more relevant. At this time, I think we're pretty conservative, as you mentioned earlier, Bruce, about saving treatment for if or when an individual has symptoms and not exposing them to potential toxicities without ever having evidence that they will need to be treated in the future.
Okay, well, thank you. And with that, thanks very much for participating, and have a great day.
Thank you so much.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.